glory, honor, and adoration. We thank you, Lord, for the gift of life you've given unto us. We thank you for bringing each and every one of us here. We thank you for traveling mercies. We commit our program this morning into your hands. We pray, Lord, that your presence will be here. Holy Spirit, we pray for your wisdom, understanding, that whatever we're going to learn here, my God will be able to understand it, even in the name of Jesus. We pray for anything persons, we pray, my God, for tuition. We pray, Lord, for your wisdom upon their lives, for teachable spirit. At the end of it all, my God, all of us will be able to benefit. We thank and bless you, Lord, in Jesus' name. Amen.
Amen. Task us to say. One. We say task us to say. One. We say task us to say. I welcome you all to this August vacation. We thank the Almighty God because we are coming from far away. And we thank the MotecLife-UK for making our conference very easy for us to plan. Because without them, we would have sought out for resource personnel and other people. But this morning, we thank everybody for being here. And it's my hope that we will all benefit from whatever we are going to learn from here. Once again, I say welcome. Thank you.
We want to have an address from a representative from MotecLife.
Good morning, everyone. We're very happy to be with you today and for the rest of the week. MotecLife-UK, as you probably find in your folder, is a medical charity with all the various professionals within the hospital setup, being members, including allied, medical, nursing people, logistics, lawyers, whatever. And when the request came from your executives to deliver a lecture or run a workshop, we're delighted to be part of it. And essentially, we're going to learn a lot from you. What we are here to do is to tell you what most times we do in England. And then you tell us what you do here. And hopefully, we'll learn from you and you take something from what we are going to tell you. Now, the only way we can change a system is that we help each other. There are some things we'll learn from you and other things you learn from us. And I hope that you go away with some messages that can help you develop your own skills and the protocols that you need to implement to help your patients. Now, I don't think I intend boring you with a long speech, but I would like to introduce some members of my team who are here today. Others will join me along the line. On my immediate left is Mrs. A. Jackson. I tell you what, without Jane, this program wouldn't have happened. She's a clinical nurse consultant who looks after pre-operative assessment of patients in England. On top of that, she's an honorary lecturer at the Hertfordshire University in Hartford. She has several years of experience as a nurse and also directing patient care from the wings, also within the hospital. So we are delighted to have her with us today, and she's going to run the show. As a matter of fact, I have said it already. She would like you to run the show. Now, behind, you see a few other people. The gentleman who is on Yahoo Expressway called Avidas. He's a big specialist in England who also participates in the lecture. together with who works on it. He has another job in England he does. As a matter of fact, he's a member of the British Police. So watch it. Not just that, crime scene detective. So watch it. He is one of the leading members of charity and very hardworking. My name is Paul Royata, one of the members of the executive of MotecLife. We started about 5 years ago. One member appeared to me in the morning asking me what MotecLife stood for, so I'll try and explain. Essentially, MotecLife initially started to move orthopedic trauma people to try to help with education, and we're going to count on our capacity, our capability, which is MotecC. And eventually we felt that we should look after life, all aspects of life, health care, promotion of health. So it became MotecLife, and of course we are based in the UK, and therefore our charity became known as MotecLife-UK. Now, we got scripts on your folder which you can read, and I sincerely hope that we're all going to enjoy the workshop. Now, one thing that I would like to say before I hand over the mic, there has been a lot of changes in our practice in this country. Peri-Operative nursing was not something people were talking about probably 30 years ago. Nobody knew about it. Where the peri-operative nurses will go depends on you. You are a force. And as a force, if you want something to improve, you can do it. Nobody else can do it for you. Thank you very much.
And then MotecLife just had a briefing on MotecLife. Now, this is a conference, one of our annual conferences that we've been doing. But this time around, we thought we should extend it to other nurses who work around us, talking about nurses who work in surgical units. So that's how come we have more colleagues around here, not only limited to Peri-Operative nurses. Registration is still in progress. Those of you that haven't done that, please try and do that. Show your receipts, your checks, and so on, and they will sort you out. Everybody is to have a form like this, which you fill with your name, your job title, if you are sister or staff nurse, you indicate it there. If you are here, just right here. And then your area of work.
I've been a nurse 35 years. Gosh, it makes me feel old. But I've loved every day of it. Very, very passionate about nursing. And somebody asked me recently, what is it about nursing that you stayed with it for so long? And I think it is the patients. From training, I went into intensive care and worked in intensive care for about 12 years. And we saw every different type of patient coming through intensive care unit, and from there into surgical care. And back in 1993, so quite a few years back, I was asked to come off my acute surgical ward and to guarantee every patient a bed on the day of admission. And I thought that was absolutely impossible. And in the UK, patients would be told the date of coming in, and just like here, they would arrange their work and their family around that and just arrive on the day. And what we found was that patients weren't prepared for their surgery. They came in still taking warfarin, aspirin, which meant we couldn't operate. Other patients would come in and they had diabetes, high blood pressure, other issues which had not been properly controlled. So they weren't fit for surgery either. And others just didn't turn up. So we prepared for them, but they didn't know. So as a result, I started to think, how can I be sure that the patients that arrive are going to be fit for their admission and fit for surgery? And I devised a means for a clinical hospital, and I called it Peri-Operative Assessment. Nowadays, I would think I should call any development like this patient preparation before surgery. And so I have amended all of my slides for you to introduce this topic as patient preparation. Right? So we'll see how that goes. While I've been doing this preamble, we've managed to get the computer systems working. What you've got on the screen are slides from my home village. These are traction engines, very old machines which we nurture, and they come up and go around the village. And there are other scenes around, scenes of the snow. So we're -4 degrees there at night at the moment, so it's pretty chilly. And they're going to have snow within the month. So the big white slides that you see is when we've got thick ice outside. Okay. In terms of the groups, let's just have a little look and see what those groups are. Just move my papers a second. Now Ghana has Ministry of Health. Your Ministry of Health has set out strategic objectives for healthcare in the region. And we're going to look at those later on. But these challenges are based around the strategic expectation of you within healthcare and the challenges that Gerald has put forward for you to achieve this week. So I'm just going to move through a little bit here. These are the group presentations. Group 1 will be looking at the patient preparation for Ghana. What is the process at the moment of patients going through, and what would you like it to become? We're going to give you the skills in order to process and map your patient's journey, and we're going to help you do that initially today. Alright, so we're going to do some process mapping. The second group will be looking at the recovery area, quite specifically. So what is it that we can do to help in the recovery department? The next will be theatre. Infection control is group 4. Group 5 will look at the documentation that you're using. Okay. Is it giving you the best that you need? Can you quickly see where the problems are? Or is the documentation needing to be addressed and improved in some way? It might be fine. That's okay. Right? The whole objective of this week is to identify some skills which are taking place elsewhere, and you might like to cherry pick. I have that bit from there, that from there, but what I'm doing in some other area is fine. I don't need to change it. And that's all right. Group 6 will look at communication. How do we communicate what we've learned about our patients? What are we communicating and how are we going to do that? And group 7 is looking at the role of the peri-operative nurse. So those are the main groups. Okay? Any questions on that? you've finished filling in your white sheets of paper, Leslie, I think, perhaps Leslie, could you do a last, just check that everyone has handed in their white slips of paper? Because Leslie is going to allocate your groups according to the objectives you've written down on your paper in your work area. Once you know your group, I think that will actually help you to focus onto the appropriate discussions and lectures that we're going to hold. This is going to be a very two-way conversation. It's not just going to be me standing here talking to you. I'm going to need some feedback as well. Just turn this off. Nowadays, patients get to know about health through many means. Yeah? I have patients come to me in assessment clinic with reams of paper which they printed off the internet, and they want the latest hip or knee replacement or the latest surgery for gallbladder, and not every hospital in the country can provide that. So I can understand when there are differences in your health care in Ghana. We have differences as well in our healthcare in the UK. The important things are, though, that our patients now are better informed. If they're better informed, they are going to challenge us. So we need to be better informed too. Our society as it is, multicultural society, multi-religions, we need to respect patients. I am so impressed with what I have seen here. I read before I arrived and learned that primarily there are two main religions in the country, Christian religion and Muslim religion. And what I see is the two working side by side. And that's wonderful. We don't have such a relaxed atmosphere that way. And there are political tensions in the UK and in Europe. And so that taught me something instantly as soon as I arrived. And that was wonderful for me to take up. But the age of our patients is increasing. Patients live longer. We have drugs to help patients live longer. And patients expect that they're going to survive a longer time. But when they're thinking about that, they're thinking that they're going to be well. They're not thinking that they want to survive longer, but in ill health. So our objective is to how do we help them to remain well. Because an increase of age means an increase in comorbidity. That means ill health. Primarily, that's cardiovascular and respiratory problems. These are the two main areas which, as peri-operative nurses, we are very cautious about. Respiratory, cardiovascular, are the two key areas that we need to focus all of our attention, or most of our attention, I'd say 90% of it, in preparing your patient for surgery. So we're going to cover both those areas this week. Now, chronic disease is our biggest issue. I can't read the main statement there very easily, I don't think, from the very back. Okay. This big line here is musculoskeletal problems. And in the UK, we have a major problem with people with bone issues. Osteoarthritis, rheumatoid arthritis. The older they get, the more the issues there is. But diabetes is a tremendous problem, not just in the UK but worldwide. 366 million people died worldwide from non-communicable diseases in 2008. So these weren't infections. These were things like diabetes, respiratory disease, cardiovascular disease. It's a mega number. Diabetes, globally, there are 285 million people with diabetes that we know of. Many others are undiagnosed. You have diabetes, over to you for the floor, we'll ask you a question. If you're diabetic, what risks are there in having surgery? Put your hand up and I can focus my eyes on something else. What is the risk if you're diabetic of having surgery? Yes, sir. Yeah, delayed healing is one. Any other risks for diabetic patients having surgery? Got a shy group.
No, what is it? Thromboembolism.
Yeah, thromboembolism. There's an increased risk of venous thromboembolism, blood clots. Yeah, absolutely. Another one. I'm going to have to come down because I can't hear over the fan. So, leading process to inflammation levels. Yes. Anything else? Anybody else? Any other thoughts? So infection is the other one that I was going to come up with. So fantastic. Well done, everybody. So that's just one medical condition. The diabetic patients, of which there are many, are prone to infection, thromboembolism, blood clots, delayed healing. That means they're going to be in hospital longer. So your next patient isn't going to get a bed, which means theatres aren't going to have a patient to operate on, and you've got all the staff being paid for, all the equipment there waiting, but nothing to do. Yeah? So we've got to capture these patients before they come in to make sure that they are fit to come in. Okay, I'm just moving forward. You'll get all these slides. But what I just want to do is just add a couple of slides looking at what your health minister has set out for you. These are the 10 most common causes of death. This has been collated regionally and districtly. This is from your own Ministry of Health website. Malaria is the biggest cause of admission, followed by pregnancy with complications, and so on. It's a completely different list to the UK list, understandably. But this is what we are going to be working with, your patients. And these are the causes of death. Malaria, a huge figure. I don't think that Peri-Operative assessment is going to address that one. But look at your anemias. Sickle cell anemia is a major problem. Pneumonia, chest infections, cardiac disease, hypertension. And I suspect that when the hypertension data comes out and they repeat this study in a couple of years' time, that hypertension will have gone up a notch. Hypertension is a big problem that we're going to realise. So your Ministry of Health has a national vision, which is to create wealth through health. That means that then that health information will contribute to the attaining middle income status of our areas. Because if you're healthy, you can work. You're working, you get an income for your family, but also as a country. Yeah? So, wealth through health. Okay, so the 5-year plan objectives. Promote an individual lifestyle and behavioural model for improving health. To scale up the services that we've currently got to meet the needs and to target those who are disadvantaged and vulnerable. The next one I quite like is to invest in strengthening the health service. That's brilliant. You have a government who wants to help you. So what we now need to do is make sure you have the skills to put that into action. There are policy from the health sector, which we're looking around mother and child, good nutrition, and the next one down was preventing infections. So we're looking at reducing the amount of HIV and AIDS, and yes, we all have a role to play in that with health education of our patients. The bottom one, reduce risk factors associated with alcohol and tobacco, lack of exercise, poor eating, dare I say it, unsafe driving and stress. I don't know how you drive here. Certainly in a car, I'm glad I'm a passenger. I think if I was driving, I'd put in the car and shut my eyes and hope I got there. Cars seem to come four angles, so I admire your driving skills. How would I not that? I have no idea. So you are going to have an enhanced quality of clinical care. You are going to be given support to promote the awareness of a healthy lifestyle. There's going to be an immunisation programme, and we're going to improve early detection and management of communicable diseases. Okay. At PONGG Teaching Hospital, fairly recently in 2007, are many of you from PONGG? No? One down there. Two. Excellent. Welcome. One of your colleagues has done some work. Dr. Alfred Doppler. I'm sorry if my pronunciation is wrong. He has identified that 70% of all deaths at the hospital are caused from hypertensive conditions. That's a massive figure. And what is so simple to control by doing a blood pressure, and then addressing the needs. The challenge that we have is making sure that patients actually comply with the medication, even when the reasons are now normal. They think, well, that's fine, I don't need to take tablets anymore. But of course, they do. It's only normal because they are taking the tablets, as we know. Right. So how are we going to introduce those health sector targets in the Ministry of Health here? What resources have we got? I think the biggest resource that we have is not a financial one. The biggest resource is you. You, the ones that are going to be able to drive forward healthcare in Ghana. Okay. So back in the UK, back in 93, I've already mentioned that I was asked to guarantee every patient a bed. I'm flicking through some slides here because I did some ad-libbing while we were trying to get this on. Patient preparation was what we set out, as I said, back in 1993, when we wanted to introduce all these changes. So they were identical. I've lost mine. They were identical challenges that we had in the UK. Financial ones, a service that was already struggling. We already had historic practice which was well entrenched. But suddenly we had to think differently. Naturally. Could we do this a different way? Was there an easier way? One that saved us time and trouble, but benefited the patient? So, Peri-Operative assessment did exactly that. I'll get back to that. These are the 4 sites of West Hertfordshire Hospital, which is where the majority of us here today will come from. I am based here at St Albans Hospital. I do a lot of work here at the Watford site. And this is Hemel Hempstead Hospital. So quite a few of us here today are actually based at the St Albans site. And this is where we do a lot of our orthopedic surgery. Sorry, my mic is going. I have some spotlights. Right, is that any better? Actually, it feels better. Yeah, I'm not getting bounce back. Okay. So patient preparation is what I put up on here. This is what we're going to do now this week. We've done the outline. You know what your government wants us to do. We're going to identify that our patients are in health or ill health. We want to consider the comorbidities of the patients. Does everybody know what a comorbidity is? Not co-mortality, comorbidity. Can anyone name a comorbidity? No? It's ill health. We're looking at asthma, diabetes, hypertension. They're things that could, left unchecked, endanger health. Alright? So they could become a morbid situation, i.e. the patient could die, but these are things which affect their health. Comorbidity. We need to identify that and identify it accurately and fully. We're going to need to provide health education to our patients. The education you need to provide is not the education necessarily I need to provide. A very small percent of our population have sickle cell disease, very high percentage here. Malaria, none of my patients have malaria. That's quite a common problem here. Chest infections, a high problem here, less so with us. So we have different issues, but in your history taking with your patients, we're going to cover history taking in a moment, you're going to identify what are your patient's individual health needs. When you know that, you need to use your knowledge and your skill to identify how you can improve their health, optimize them. You need to optimize your patient's health before admission, or certainly before surgery, so that they don't have the stroke on the table because the blood pressure hasn't been checked properly and the patient hasn't had their medication. You might want to advise on smoking cessation before surgery. Okay, another question. Why is smoking cessation important before operations? Can I hear something here?
Chest infection.
Yep. Yep. So prone to chest infection. Anything else? Yep. Okay. So we've got liver disorders as a result. And liver disorders was mentioned. Chest infection mentioned. Any other problems with patients smoking right the way up to operation time? We've now got Leslie with a voting line. Is there a gentleman? Yeah, what comes to you, sir?
What I'm thinking is maybe the cigarette contains stimulants to not put the patient in the right position. We want the patient to stay away from it.
Right, okay, yes, yeah, that's making sense. We have a gentleman over the side there. Query. Comment.
It can also cause a negative outcome in anesthesia.
Right. So challenge anesthesia. Okay. So infection is a big problem for the smoker. Chest infection. We're going to have atherosclerosis. These patients, their arteries, their veins are going to firm up. So they're at great risk of developing a stroke, CVA. Again, one of the biggest issues is infection. But these patients infect very easily. The wounds become infected. And they don't heal. And then you have a later infection, secondary infection set in. So it's a big problem. So smoking should be reduced before the patient comes into hospital if it's not stopped. The patient's oxygen levels in the lungs will improve with every 24 hours they stop smoking. You get higher oxygen levels, then the oxygen is going to get to the tissues and heal where you cut. The tissue is going to heal more quickly. And once the cut is healed, of course, there's less chance of infection getting in. We also plan the length of the stay the patient is going to be in hospital at patient preparation in the UK. Whether you decide you want to do that here, I'm putting it in the melting pot for you to pick out that objective. The one other aspect that patient preparation does is look at discharge planning. So that you plan the discharge before the patient has an operation. That way, if you've done a correct preparation for surgery, you know the patient is going to be well enough to have the operation, you come in, have the operation, and you know that they're going to be fit enough to have the op, you should have them recovering at a quick speed, ready for discharge back to their community or wherever else they need to be going. So we discharge plan even before they come in the UK. And what that is patient-centred care. Okay. So in the UK, practice in the community is called primary care and the hospitals are called secondary care. So what we are doing is linking between those two. The important bit is the second point, that the care is planned around that individual patient to maximise the care that we give to the patient, minimise their length of stay in hospital, and ensure that they can get back to the community rapidly. Who should do pre-operative assessment or patient preparation? Should it be a nurse? Should it be a doctor? Lots of debates have been had over that over the years. I actually maintain it's neither. It's interprofessional teamwork. So it's neither one nor the other. It's collective. And in my clinic, I have care workers, so unregistered nurses. I have registered nurses, pharmacists, and an anaesthetist. When we have the need, we will call in a cardiology team, diabetic team, clinical team, and so on. So we'll call in the expertise of the individual patient as we need it. So what I have done is look at the length of stay of patients to say if they haven't had an assessment before admission, before surgery, does it alter a length of stay? Can we prove that preparing the patient before admission does genuinely affect that length of stay? Well, let's have a look. I actually found that overall there was a considerable reduction. I assessed patients, And I had a registrar seeing patients as well, and I had a control group that had no assessment. And we found a highly significant fact that to a value of P is less than 0.001, which indicates a very strong factor that nurse-assessed patients, and I stress that, nurse-assessed patients, actually have reduced length of stay over and beyond those seen by a doctor or none at all. So a trained nurse can assess a patient more and have an effect on their length of stay quite dramatically, rather than a doctor assessing a patient who tends to be looking at the immediate problem and not before and after this, and not doing the discharge planning, not looking at the patient's other comorbidities and giving them health advice. We're better at that as nurses. I think the other thing that we're perhaps better at is applying a protocol. If we're told we need to do something, we do it. There's a standard set, we will apply it. Doctors are far better at applying individual treatments to individual patients. We're not quite so good at that. So that's why we need to work together so well. Age range of patients that I see, you know where my experience lies, 16 up to 101 is my oldest gentleman. And he came in for hip replacement and just stayed 1 day longer than the young patients. And he did fine, no problem at all. And he only stayed 1 day longer because we had prepared for his admission. His family were prepared before he came in. There are guidelines to help. But now, really, what we need to do is looking to see how we can help you to affect your patients' length of stay and early discharge, as much as making sure you have accurate histories being taken. So, what I'm going to do is close this down. Oh, actually, no, if I close this down, I have a challenge here as the strategic vision. Do we know who's going to be Group 1 yet, Leslie? Yeah, we do. Group 1, I'm looking at them doing a strategic vision. Saying that. Sorry, Group 7. Leslie, do you have Group 7 up there? Do I have them? Oh, 5 minutes, okay. So in 5 minutes it's going to come up on the board. So Group 7 will be looking at the strategic vision of patients. I'll give you a copy of the strategic vision for Ghana, so you've got that to work with. And what you'll be doing is looking forward which of those aspects of the strategic vision you can take forward in your healthcare areas. What do you need to do to promote that strategic vision? Who needs to be involved, and will there be any training needs? There might be. And you're going to identify how you're going to proceed to implement your action plan and put a timescale to it. How are you going to know that you've been successful? Or how will you evaluate it? Audit. Alright? Don't worry about writing all of those points down. You're going to get a copy of the actual questions. Okay? So, Group 7 will be strategic planning. Okay. Questions on that before I move on to the group work? This question here. Oh, lovely, thank you. Broken mic is coming. I'm trying to speak slowly
primary care and secondary.
Sorry, I got secondary care bit, I just like the rest.
The difference between primary care
And
and
secondary care. So what's the difference between primary care and secondary care? Primary care in the UK is the care in the community. So it's looking at everything outside the hospital. Secondary care is where the patient has been referred onwards to a second position, if you like, to the hospital. Alright? Any other questions? Okay. Has anyone thought of any objectives that are not met yet that there are? By all means, add on. Okay. I'm going to do a bit of history taking next. Because I've reduced my slides, I didn't have everything up on my front screen, so my apologies about that. I'll find it again. Okay. Would you all take patience to take a moment? Hands up for you. Oh, okay. No problem. This is exactly why I chose to move this slide forward to today, because I've got lots of hands of expertise here with me. We're going to look at how to take history, then you're going to have a go, and we will collectively, as a group, feedback. Okay? So you say you're going to start to get some hands-on work now. I've done enough talking. Okay, here we are. So do you all now know what is the aim of patient preparation? Tell me, what have we been talking about? What is the aim of patient preparation? Got the broken mic? Two leader givers.
The person will prepare the patient to allay his fears. To allay his fears.
Yes, it's related to it. Thank you.
To identify any existing conditions.
So we can identify the vulnerabilities and health issues and address those. Anything else? Yeah.
to prevent post-operative infection or complication.
Excellent. So we're going to prevent post-operative complications. Yeah, we'll get there.
To allay patient anxiety. Anxiety.
Right. Somebody help me out?
Patients anxiety.
Anxiety. Thank you very much. Thank you. Anxiety is an issue of my life to visit. I think that's one of the biggest things that we have difficulty to measure. Patients are very anxious before they come in.
The last time the patients say
Yes, yep, definitely. So we're going to assess the patients and minimise their length. How do you mark your patient's theatre? How do you know it's the right or the left? You mark it on the skin. Big arrow. Right. Okay. There's another one that we haven't mentioned yet. Investigations. So patient preparation is a perfect time to make sure you've done the right investigations before the patient has their operation. Your diabetic patient. Have you maybe 2 investigations, blood tests that you want to do for your diabetic patient? Somebody here?
Blood sugar.
Yep. Okay, lovely. So blood sugar and urine. That's excellent. So we're going to do either a finger test or to check their random glucose level. We also are going to do a urinalysis to see whether they've got sugar in the urine. And I would suggest that if you've got a diabetic, you also need to do a test called an HbA1c. So it's hemoglobin, big H, or by writing down here. An HbA1c is looking at the red cells of the body. I'll check my pen, hold on. There we go. It's HbA1c. So the red cells in the body last for how long? 12 weeks? Yeah, 12 weeks. Sorry, this is going to be very difficult to hear on in. I am going to be firing questions back, testing your knowledge. So a red blood cell lasts for 12 weeks. As it's circulating around the body, different elements are sticking to it. One of those elements is glucose. So, if we look at the red cells, we can analyse how much glucose there is, and the pathology department are excellent at telling us what average sugar level that patient has had over the last 12 weeks. So no sneakily avoiding chocolate and alcohol the day before their admission. This is actually going to look at the whole 3 months beforehand. This is a very accurate reading as to how good that patient is in their diabetic control. Okay? Every diabetic patient should have an HbA1c, and we only repeat it every 3 months because there's no point repeating it earlier because the red cells last for 3 months. Okay. So you're going to assess your patient's fitness for surgery, and you're going to be aware of their holistic needs, their total needs. That's social care, it's their family care, it's the patient's health problems which are additional to the reason they're having a surgery. So they might have a hernia, you're assessing them as a whole person, not just that hernia. Looking at adult patients, paediatrics is separate. The first thing we need to do is look at the environment that you're going to see the patient. Do you have an area when they can confide in you? They might want to tell you something which is very pertinent for an anaesthetic, which they haven't told their family or they feel embarrassed about. Like a young girl who's pregnant and her mum and dad don't know it. Yeah? Look at your environment. Can that individual be honest and open with you? Because if they're not going to have a safe admission. And who will look to be at fault if we'll actually take them back for that. So it's important that you get the knowledge from the patient which is accurate and is true. All of the documentation that you're going to put in, you need to make sure that it's dated, it's timed, your signature is on it, and your name is printed on it. Why? Why am I going to want the signature? Identify the person that's written it, yeah? So another health professional looking at that can come back and say, you've written down X, can you explain why? Or can you give us more information? Yeah, great. Why do I want something timed and dated?
more reference, also because of the legal issues.
Definitely. Referencing is the key factor here. As we will see when we do ECG interpretation later in the week, patients' conditions can change. So it's very important to date and to time what we're doing. Patient comes in and you've taken their history and they've denied any health problems or any cardiac problems, and suddenly they have chest pain on the ward. You've got 2 ECGs, one from admission and one after the chest pain. How do you know which one is which? Yeah, done on the same day. So you need to date and time everything you do, so you've got a timeline. Yeah? Always begin with the current complaint. So tell me, James, what is it that brings you here today? And you confirm to me what operation you are expecting to have. And is that on your right side or your left side? Now the reason we do it that way round, rather than saying, hello James McDonald, with your quick name, you're here today for us to talk about your left hernia, that doesn't confirm to me that that patient knows why he's here. Neither does it reassure me that the patient I think I'm seeing is the person in front of me. Yeah? We have a name in the UK which is very common. It's called John Smith. There are thousands of John Smiths. And I have had several occasions in the last 10 years where I've had 2 people in the waiting room waiting to be seen with identical names. Very difficult. Both coming in for the same procedure, one on the right side, one on the left side. So I needed to think, how am I going to differentiate these patients? So ask the patient to tell you, why are they coming in? Who are they? Yeah? We would check with date of birth, their address, their name. So you need to have some identification that you can use locally here too. We also use hospital numbers and case notes, but I'm not past that now. Whatever the patient tells you, you need to check if any missing information you've already got. Anything you write down must be accurate without any interpretation. It's factual. So you're not interpreting what that patient is telling you. It needs to be easily read. I don't know whether Mr. Horiato, when he worked here, or who you met earlier, I don't know whether his writing was as bad as it is now, but right now when he writes, I think the spider's gone into the inkwell and suddenly worked its way across the paper. So I'm always smacking him on the wrist saying, come on, I can't read your writing, make it more clear. What is the danger if you can't read that writing? So it's misinterpretation of what the person has written. It might be the patient needs to have a very minor procedure and actually you interpret it incorrectly to a very big procedure. And golly, how scary that would be for the patient if you suddenly talked about a huge procedure and they were expecting a tiny cystole removed somewhere. So it's important that everything that's documented is clear. If it isn't, challenge who wrote it, go back to them. So just like I go back to Ford and say, you've done it again, come on, what's this say? let's write it out in capital letters here so it's clear. You need to do that too. And never ever abbreviate right to left. There are many other things that one should never abbreviate. It's easy as nurses to write an R. I don't know if this is going to work, but I will try. So it's quite easy to do an R and stick it in a circle. You can also do an L and stick it in a circle, right and left. And that looks relatively clear. But there are times when people have done that one R, but actually that could be interpreted as an L to the left. Yeah? As you start to look at the knee replacement, you'll have the same issue. A THR and a TKR is clear if you've got the top of the H and the K separated. But as soon as you start to do it in a rush, they merge. So they have to be written in full. Knee, hip, right, left. Okay, move on. So, in a moment, I'm going to ask you to split into groups. How many of us are there? 1, 2, 3, 4, 5. Okay, so I'm going to split you into groups, say of 6 people. Okay, thereabouts. And what I'm going to want you to do, one of you needs to think through some health problems. You're going to be the patient. And I'd like the others of the team to interview you. And what we're going to do is find out if they are asking you the right questions to get the history out of you that you have. So you don't read them, the answers. So those of you that are happy to be the patient, you can swap around if you want to. Think of complex health problems. Yeah? No need to tell keep interviewing you what those problems are. It's up to them to get that information out from you. But the interviewer will listen actively. They will adapt the questions so that the patient can understand and comprehend them. They will reflect back. So you're telling me that you're coming in to have a right angle hernia repair, hernia with the groin repair. Is that right? So they're echoing it. They then will summarise what has been said at the interview and watch out for any non-verbal cues. What if the patient is hesitant to get up at the end of the interview? Are they thinking, actually, do I ask them that, do I tell them that, or not? Look out for that. Okay, is there anything else you want to ask? So, what you need to know when you're recording down a medical history, you'll need to write this down. You're going to start with the patient's complaint, which we had on the previous slide. You then are going to look at their operations in the past. When did they have those operations? Were there any adverse anaesthetic problems? And are all operations necessary to be put down? Well, certainly if they involve a general anaesthetic, yes, from the ear dot upwards. There's an anaesthetic problem with a drug that was used 30 years ago. It might not be a problem today because we no longer use those drugs. So it's important to date when those operations were approximately. When I was age 10 is fine, or 5 years ago is fine. You're going to record down the past medical history. Those are the conditions which I I'm asking you now to think of, and any relevant family history. So some families have a gene which causes an anesthetic problem. It's passed down generation to generation, and when patients have anesthetics, there is a major interaction adversely. So we have serious problems in the theatre table. Social history may be relevant. What if the patient coming into you is going to be with you for a week, and when they are going home from here, they are not allowed to lift anything. Maybe they've had a disc removed from the back, but they are the main carer for their parents. So, how is that patient going to manage when they go home? You don't need to organise the management, but they need to give that some thought before they come in their operation. And you need the assurance that the patient's not going to undo the good work of the surgery and your administrations within hospital. Smoking, alcohol history are all pertinent. We've covered the reasons why. Okay. What's the difference? How much alcohol do you drink per week? Or how much alcohol do you drink in a typical 7 days? Which will give you the most accurate answer? Top or bottom? Bottom one. Yeah? Many patients that I see who are drinkers, those who aren't drinkers, it's not a problem, either question, but those who are drinkers will use the top question to say, oh, I don't drink in the week, but at the weekends, they're out for the match. Yeah? So, be specific. What you ask is what you're going to get back. If you ask a specific question, you'll get a specific reply. Alright? Okay. So your medical history will identify any potential risks that's going to impede the patient's safety and their recovery. Your medication and allergies, very important. Medication, there's those that is prescribed for somebody, and there's drugs that patient just pick up at a pharmacy or herbally. All important that can be taught. Okay? And lastly, you want to check, you don't need to do this practice right for you, you don't want to, but always check that the patient understands the operation they're going to have. You know the risks, the complications. Have you had the leaflet? Has doctor spoken to you? Whatever your current practice is, you need to make sure that that's covered. If there's information, please use it. I've already spoken about the social. Okay. So, what I'd like you to do then is to split into groups, and one of you elects to be a patient. We'll change it around. We're going to spend 10 minutes on this, nice and quick. And the rest of you, one at a time, ask the patient questions to elicit what they're coming in to have done accurately. To find out what's the past operation and medical history. We might, in a clinic setting, look at their height and weight. We're not going to do that today. Look at the past operations, any issues, the medication they're taking, any allergies. Do they smoke? What about alcohol? Any family history? Any social history? Okay? You don't need to have fancy pro formas for this. Sheet of paper is all that's needed. Blank sheet of paper. There are pro formas. I will be looking at those later on. Don't need them. So, try to split this off into groups of about 5 or 6 people, and we'll get going. Alright, we're going to have 10 minutes for this, and then we're going to be breaking shortly after that. So, are they diabetic? Are they asthmatic? Blood pressure? And when they say yes, they're diabetic, for instance, you're going to ask, when was that diagnosed? How do you control it? How are the levels? How do you test it? Yeah? Are you under the care of anyone for your diabetes? To get some bit more history about that. Yeah? Is that all right?
Yes.
Good.
And then maybe choose one person to be writing down. Do the writing, all right? So, and then when it's time, one of the
Yeah? So who's patient? Hello there. You've got some good history there, I hope. Well done. Brilliant. And you're taking it in turns to ask the questions, yeah? And you're going to explore what it is. If the patient has diabetes, you're going to explore when it was diagnosed, what they take from it, what's after diabetes and so on, yeah? Yeah? Okay. Good luck.
I think the patient particulars is not enough. Let's go to
So at this time,
what
the
is
patient has been diagnosed.
No, you are taking it. You are taking it.
what is wrong with you?
My head aches. I have palpitations sometimes. When I sleep, I urinate. Sometimes. When I sleep, I urinate maybe 5-6 times before morning.
So you do what?
Frequent.
So do you say no?
Now he said
frequent
frequency of it,
iteration.
so you will prove further to know whether it's polyuria. Hey.
Hello.
Hi.
Hello. Good
Hi.
afternoon. Good morning. I'm from MotecLife from England. So we just more or less try and see how you are getting on. You've chosen a patient,
Yes.
and this one seems to be doing the writing.
Yes.
And is he going to present it, or somebody else is going to present it?
abdominal pains. Yes. Which part? The gastric.
I'm a patient.
Yes, I know. Is it so the whole abdomen?
No, not all. Just up here.
The gastric.
This thing has been worrying me for the past. I say it has been worrying me for the past 6 months. Each time I go to the hospital, the doctor will ask me, give me medicine, but when I take it pains me more. And apart from that, from there, you know the type of medicine, white medicine, round, small one.
More white,
Yes,
round
white
medicine.
Yes, he's been giving me. And one thing again is,
Are you on medication?
Have you seek any advice concerning that?
Yes, I went to the hospital about 2 months ago to detect that I'm sick.
And so
About 2 months ago, that I'm having diabetes.
2 months.
About 2 months ago.
How was your sugar level around that time?
My sugar was 11.5.
First visit.
Yes.
11.5.
just a general headache.
Because she's writing, you have to.
And I was asking whether the headaches felt on the left or the right side.
Just in general. Yes. Actually,
Is that
It should
be-
have a scale so we will check it.
yes? But the history, are you like it? Is that severe headache and headache? And then she mentioned
how long have you been?
how long have you been prescribing?
See, I said yesterday, you definitely have to.
This yesterday, is it in the morning, in the afternoon, or after in the evening, or in the night?
National Hospital. I live just in front of the hospital. Come here.
Come again for me.
Just
Background, social history, who she is, where she's come
And then after we ask them about the hygiene and the weight, it's our responsibility to pay them BMI. That's the body mass index. The reason why they do that because we have to go nutritionally if they are underweight or if we need to refer them down to the dietitian. So normally it's the height and the weight gives us the BMI.
Somebody can hide for us. Hide about I am about this. What is something
Right. We do have any past medical history. We have any past medical history.
So what do you ask? How many talks a day?
In the night, 2 talks. 2 talks in the night.
Every day.
Yeah, every day.
And all the physical way, we said you were ready. Social, if you take 2 talks, so what can we do with anesthesia?
Like your last.
Am I married?
Your lifestyle is an activity. Lifestyle. Explain it to me.
Like if you have some hobbies, fine. We have or
Family history.
Said the mother is a diabetic.
So explain social history, like what? Social history.
2 more minutes. 2 minutes.
So now we start. Put the date down. Put the date down. The date. Just write the date.
Susan.
Kumadi.
Auntie Susan, how old are you?
I'm 20 years old.
Yeah, how can I help you? What's your problem?
I've been experiencing
I am one, so I know where you get it from. That's where you get it from, family. And then you coordinate it like that, and you find that. So you can actually write it in personal, medical, family history. And then you can family history.
Before. So I purposely wanted to let you have a try with a blank sheet of paper, blank canvas. Was it easy? No, it is not. If it's not easy, that means you won't have been accurate, potentially. So what were the challenges? I'd like to let us know what the challenges are. Abby is going to write down the challenges that you had in that exercise. What were the problems? Want to shout out?
Getting the actual information that you need for the patient, because the patient may start talking about something else.
Yes.
And whilst you need different information altogether.
Indeed. So the problem is that difficulty getting the patient history, because the patient is wandering in their thought process, going away from the question that they're wanting the answer to. Big problem. Any other challenges that you had? Yeah. Right. Okay. So the operation is looking at one specific part of the patient. Actually, you need to look at the patient whole. So perhaps didn't have any guide as to what other aspects you needed to look for. Right. So it was a lack of a defined pathway of questioning. Would it have helped if you had a questionnaire to go through? Okay. Any other challenges?
Most of the time, the patient don't know the names of the medication given. Just describe it, quite round medicinal they were given. They don't actually know the names of it.
Right. So medication, a small round white tablets I take every morning. Ooh, what a problem. I don't know how many thousands of small little white tablets there are in existence, but not at all. So medication is a big issue. So it's important when you communicate with your patients, get them thinking about every time they visit the hospital, they bring their prescription with them or any tablet medicines, herbals that they're taking. They bring their carrier bag along with them. Yeah? Any other challenges?
Well, like past medical history, if it happens a long time, the patient forgets some
vital information.
Right.
So collecting it is very difficult.
Yep. So accuracy in terms of when procedures have happened in the past is very hard to confirm with the patient. They get a bit woolly about, well, I think it's about here, but actually maybe it wasn't. So you can't get data out to the patient. That might not be crucial, but it could be. So you need to use a judgment to determine that. Do you want to go there and have a patient later?
Okay, talking about in Africa, most of our patients don't know their age and the date of birth.
Right?
That's another challenge.
So there needs to be found a way to identify a patient. I don't have that answer. Hold on a moment. Something to go with.
They give too many complaints that sometimes it's difficult to diagnose.
So the patients are giving many symptoms and it's very difficult for adding extra symptoms on. So diagnosis is difficult as to what might be the health problem. So that, as the nurses, does pose us some problems. Okay.
And sometimes there is language barrier.
Yes. There can be a language barrier. There can be a barrier because the patient has difficulty communicating. Maybe they have difficulty with speech. Maybe they have learning disabilities. Maybe they are vulnerable for some other reason. They've had a stroke. It's very difficult. They might have a short-term memory loss. Can't remember what's happening.
With the past operations, most patients have been operated on, but the type of operation they underwent, they don't know. So they can't give you the exact operation that they've had.
Okay, excellent. So challenges there in terms of the knowing of the actual operation. Okay, we'll take two more and then we're just going to wrap this one up.
Also, most of the patients, when they undergo the operation, they don't know why they went into the operation, especially in cesarean sessions. The patient will just tell you that I was pregnant and came to deliver and could not deliver, and they did the CS for the person. But she can't tell whether they said she had a CPD, fetal distress, or something.
Yes. Yep. Thank you. Well done. I think there's one more here. Take the lady.
Some patients also don't want to disclose of the social history and the family medical history. They don't want to disclose it. Maybe, I don't know.
So failure to disclose items, social and family history. So how can we tackle that? If a patient doesn't want to disclose, are we in our rights to demand that they do? What do you think?
I think you assure the patient of confidentiality, maybe they can tell you.
So number one is sure confidentiality, but number two, if they really are resistant, that's the patient's prerogative really to hold back that sort of information. And what I would say is explain to the patient why you want that information. So I ask the patient, can you reassure me there's nothing in that family or social history that I need to know about, nothing related to the operation or that have, or to anesthetics and surgery. Okay? That's probably the best we can do. Lassa.
So also the patient cannot give you the estimation of maybe let's use loss of blood to tell you late, but you cannot be specific whether 5 mils, 10 mils or.
So in-depth knowledge then we're going to have. Okay, let's call that hold on a moment, question there. So all of these areas, difficulty in getting a focused history, lack of a systematic approach to history taking. We were saying it was very difficult with a bit of paper to get the history. Had we had a pro forma, we might have been able to do this much more easily. So we would have been guided, check diabetes, for hypertension, coronary obstructive airways disease, and so on. Yeah? Medication, names, dosage. I have the same problem as you. Patients tell me, oh, I take one tablet in the morning and one in the evening, and I'm juggling, what is it? But with time, you can educate the patients to bring their medication with them. So accurate history taking, there can be discrepancies with what the patients are telling us. There can be language barriers and learning disabilities, and that group of patients with language barrier and learning disabilities, we are almost entirely reliant on anything written about the patient. And that's where the writing of the documentation is so important. Okay, so if you had a pro forma in which you could detail the patient's medical history, page by page, question by question, that would help. It doesn't give you the answers, but it would help. I have some pro formas. I don't have enough for one each, but I'm going to give the 2 master copies to Joel so she can copy them for you. Alright? One of the group will be looking at documentation. Group 5 will be looking at documentation. So group 5, when you're allocated, will definitely have some copies of these. Okay, thank you very much, Abby. I just want to, before we break, run through. What would you do with this patient? Would that patient be a difficult one for you to assess? He's everywhere. He's not interested in anybody else. Oh, why should I bother to answer the question? It's very hard to interact with somebody who's got their back to you or who is not interested. With experience, you have to learn how to cope with those situations, but not until you're good at taking history in the first place. And challenge them. I'm sorry you think this is a waste of time, or we're not going to be long if you can just answer these questions, yes or no, and then we'll be able to go about the daily business that you want to go and do. What about this manipulative person who twists everything that is being said? Do you get patients that do that? I do. Ask a question, straightforward one, I don't know. Are you diabetic? And they'll turn this around. What are you telling me? I'm diabetic. Why are you thinking that? Yeah? So it's very careful. How you word a question to a patient is very important. So the way of avoiding that is setting the scene. The very first slide is looking at the environment. Setting the scene, telling the patient what you're about to do, what you're going to be asking, and why. That way, they're on board with you to make sure that you get all the accurate information that you need to make their admission safe. You get these? Family outings. I have patients arrive to me, particularly in the school holidays, with the pushchair, the other 2 or 3 children in tow, and they all come into the examination room at the same time. And very often I end up thinking, oh, I can't hear myself think, let alone this accurate information here for the patient. So, where possible, we need to ask whoever's coming with mum to look after the children. If it's not possible, then I very much focus the interview to the questions that are crucial to get the answers to, rather than go into any more detail. because the patient is not receptive to knowing the fact that you want to give them about the procedure they're going to have under your care. Yeah? Okay. What about this one? What are you going to do? He is angry. He is late for his appointment. Quarter of an hour you kept him waiting. It's just not good enough. He's got another appointment he's going to have to go off to do. What are you going to do for him? Any thoughts? I'd rearrange the interview. By the time he comes into you, even if you see him straight away, his mind is already on his dental appointment. He's not interested in being with you. So mentally, he's already switched off. So, be organised. Do you ever get these ones? Patient walks in, sits down in the environment that's nice and quiet interview room, with a nurse that looks happy. She thinks, oh, she looks friendly. As soon as she sits down, whoosh, the waterworks are on. What you don't know is, has she just been told she's got bad news? Is this the only opportunity that she's had to sit down in private and she hasn't been able to breathe for her husband or her parents that aren't well? You don't know why she's crying. So close all your books to do with your interview, push them physically to the side and give her space. She's going to need it. Quite likely you'll end up doing an interview later, but it depends why she's upset. I shan't do that one. Do you ever get any written information about your patients? I expect you do. If so, what if the written information differs from the information the patient is telling you? How will you deal with that? You might need to go to the consultant. Yeah? Alert them. Patient tells me that they definitely are having an operation on the right leg, right arthroscopy knee. But everything in the notes tells me left. And it could well be that when they looked at the x-ray, they had it on the wrong way round on the x-ray screen. Or it might be he meant to write right, but inadvertently wrote left. Or it could be he had done his arm and actually it looked like left. Yeah? So always challenge, don't accept it. If the words and the figures differ on a check, you would always challenge it, otherwise you're not going to get your money. Same goes here. Alright? And then I have a lot of these. This is the highlight of her. She lives alone, she's got no family nearby, and she wants to talk, please. And as far as she's concerned, she's got an appointment for the day. Gosh, they are difficult to deal with. And as nice as they are, we need to get the history out. So there will be times when you've actually got to say to somebody, right, we have 10 minutes. I never wear a watch, I never know quite what the time is. But I actually just do that for about 10 minutes. In this time, I need to know a yes/no answer to these questions. And then I'm going to try and find somebody to go and have a cup of tea with you. and I normally find a student or a care worker that can go and have their coffee break with this lady, so that she's got someone to talk to. Sometimes it's our receptionist. But yeah, we do get those. So how do you know if you've been successful? Basically, it's because you will have had a two-way conversation with the patient. You will have asked them questions, you will have echoed back to them their response. You will have summarised the interview and achieved answers to all of the questions that you had. So two-way conversation, a patient who is informed about what's going to happen, and you will know what is happening and can plan that patient's admission. And lastly, everything that you've done is going to be clearly documented in the patient's notes. It's going to be dated, timed, signed, and printed, or name printed. Yeah? Okay. Now, as far as I know, it is time to have a break. Could one of the team just check with Joel or whoever that break is ready? In the meantime, anything else regarding that you would like to go over? This is the challenge that is going to be for Group 6, by the way. So Group 6 is going to have this challenge. We know about breaks. It was on the timetable, we had a break, that's why I was sorry. Okay, well, what I'm going to suggest then is we have time to hand up, got those thrombosis forming. Oh, we've got a break, have we? Lovely. Okay, so back in the room, then whole drink. 15 minutes break. Take 15 minutes. And the challenges that poses. The points that you noted of how it was difficult to do a history taking, I've left up on the board on purpose, because what I'd like to share with you now is how history taking can be made very easy and very safe for the patient and for us. Now, one can develop a document which has all the key questions in it, and that document I call a protocol, because it leads me through from identifying the patient through the assessment of taking their history, their observations and investigations, all in the same order, and allows me then to determine is that person fit for admission. So these protocols, I've given Joel and his team the key pages that you need to have. And as I mentioned earlier, one of the groups are going to be looking at protocol writing as their assignment. So know that these will be available for them. What I would like to share with you now, and we hope that this is going to work, we haven't had the opportunity of requesting it, is a DVD which is teaching the skills of patient assessment. It's a very, very big DVD. I'm going to choose some snippet examples of it only. There is music with it and a spoken word, and what we don't know is whether the spoken word is going to come across, so we're just going to have to see how this works a second. I'm just waiting for that to load. Was devised at the University of Southampton in the UK. I gave some assistance to its production, along with several colleagues across the UK and from America. And it has been devised to try and help people who are learning the skills of pre-operative assessment. Unfortunately, the DVD is no longer in production, but I've got a copy here, and what we're going to see if we can do is copy it across so that we can have a copy here to refer to. And it links very much with the booklets that will be given. Now, I think that there was a shortage of them this morning. Rest assured, the rest are coming tomorrow. We had to carry all of these over in our hand luggage, and so everybody was given a task of different things to bring. And the last shipment of these is arriving now. So these will be with us tomorrow morning. So let's just have a look at this a second. Taster for that, let me just find out. That was difficult, I assume, to hear at the back. So, I've got a 30-year-old
coming in to have a right ankle hernia repair. She has no known cardiovascular diseases. She used to smoke 10 cigarettes a day but has given up for the last 5 years. This lady has no other health issues. General health is good. And her previous anaesthetic, she had a tonsillectomy at the age of 6, and it was uneventful. So we've got a lot of information there. We know she's had anaesthetic in the past, but there was no problem with it. So that tick boxes the list, if you like, of anaesthetic issues that we might have with this lady. We know that she has no cardiovascular diseases, and we know that she has given up smoking. So how do those risks grade? I'm going to talk a little bit here about body mass index, the top on the right-hand side. Body mass index is a measure, it's a scale, and we look at the weight of the patient and their height. And we can determine what that overall body mass index, what the number is, that can be allocated to that patient. I'm going to be talking about body mass index in detail later on. All you need to know for now that 25 is normal and 25 to 30 just says she's slightly overweight, but that's okay. So this lady is having a straightforward hernia repair, normally a short time under an anaesthetic, and there should be very little tissue damage. Because she is not diabetic, she has no other health problems, no heart problems, and not worried about the healing. She should be healthy enough to heal without infection. Smoking is a risk factor, but she hasn't smoked for 5 years, so her risks are less than they would be if she was a current smoker. So that's a good thing too. Her observations are perfectly normal. I will be asking you your normal values for observations as the week progresses. Okay? Age. Anaesthetic risks are linked with age. This lady is young, 35, so there's minimal risk involved there. She doesn't take medication, and she has a family history of a myocardial infarction, that's a heart attack. It is a risk factor because her father died of a heart attack when he was 40. So she's only 5 years junior to that. What we do know is that women who are still have their ovaries and still have natural hormones are less likely to have cardiovascular disease than after they reach menopause, after which the risk factors are exactly the same as for men. Okay, so from that you can see having a pro forma has slotted things into a nice clear pathway. Now at a glance you can see what are the problems with this patient. And let's just have a little look and see what happens next. What is happening nurses cannot intubate the patient, we have a dangerous situation on our hands. So we need to make sure that they can extend their necks and can open their mouth sufficiently to allow us to intubate. Right? I'm not going to go more into the mathematics lesson right now. Is this quite difficult for you to hear and see? Yeah? I'm getting some nods at the back. Okay. What do you think? I'm just going to see how we can do this. IT chaps, do you think that there'll be a possibility of getting this DVD working tomorrow?
We'll be in the Yes. Yes.
Yes.
Yes. This afternoon.
This afternoon?
We will be there this afternoon.
Yep. Excellent. Look familiar? So, what I would like to do, this is not an in-depth anatomy and physiology lesson, but what I would like to be able to do with you is to make sure you've got the key anatomical features to hand, so that you can actually identify that this patient has lost myself entirely. Okay, so we're going to identify the respiratory anatomy and the association of the cardiac organs. So, I have popped up on the board that the function of the respiratory system is to supply the body with oxygen and to dispose of carbon dioxide. Anybody disagree with that? Yeah? You're all happy with that? Brilliant. Anybody know how that is achieved? You probably are all thinking, what a silly question, because we all know that we breathe. But how do you get the oxygen down from the lungs into the tissues? Got a gentleman here who's got my answer.
This works simply by where something is small, we move from there to the next area. For instance, if we take in the air, we need the oxygen, and the tissues need to get the carbon dioxide out. So in that case, oxygen is going to move from the air that we are taking in into the tissues, because there is less oxygen there. And then the carbon dioxide is more in the tissue, so it will move out into the air, because there is less carbon dioxide in the air, it will move it out.
Brilliant. Very good. Thank you very much. A good synopsis summary. Thank you. Okay. So, there are four key points in terms of ventilation. We have the airflow movement in and out of the lungs, which allows the exchange, as our colleague here was mentioning, of carbon dioxide and oxygen. That is called pulmonary ventilation. Okay? So that's the bit that we actually think of as being breathing and therefore oxygen carbon dioxide exchange. And it involves the lungs and the ribs moving, and the diaphragm moving. Okay? And then, and crucially important for patient preparation, is that we need to move that oxygen from the lungs around the body. So it has to be transported, and that is done via the cardiovascular system. So internal respiration then takes place when the oxygen goes out from the blood vessels into the tissues, and carbon dioxide goes from the tissues into the bloodstream to go back up to the heart. Who can tell me what vessel it is that transports the oxygen from the heart around the body? What blood vessel? Aorta. Excellent. And what vessel takes the carbon dioxide blood back up to the heart? The vena cava. Excellent. So here we have a young man who very kindly for us is posing with a set of lungs and trachea. The important thing to note is how high the diaphragm actually is. So it actually is quite high up here. On inspiration, that diaphragm drops down to allow the lungs to expand. You can see that we have 3 lobes on the right-hand side, 2 lobes of lungs on the left-hand side. We'll look more about those in a moment. The trachea sits here. So the air goes in the nose or the mouth and down the trachea before going in through the bronchus down into the lungs. What conditions can actually obstruct that trachea? Have you ever come across patients whose trachea is pushed to one side? Or perhaps there's something else here? Thyroid? Yeah. So a large thyroid can push on the trachea and obstruct the airway. So one of the very first things you do when you're looking at your patient is looking to see how well they are breathing. Is that trachea central? Is it pushed to one side? Is it deviated? Okay? Deviated trachea will be a problem for our anaesthetists. Anything else on there I want to show you? I don't think so. So, here's our trachea, branching down the bronchus, right and left, and you can see the bronchioles get smaller and smaller as they go down through the lungs. So at the very end, just one cell width, allowing the oxygen to transport across and the carbon dioxide. You're probably seeing the lobes of the lungs are quite clear at the top, and then you've only got this partial evidence of lungs at the bottom when you look from the anterior viewpoint of your patient. We'll look at exactly the position of the lungs shortly. Here is the bronchus, looking at our gentleman from the front. Quite low down is the bronchus, branching out to the trachea. And here is the posterior view. Important to note your anatomy, because if you ever get to the point of needing to listen to patients' heart and lung sounds, and bearing in mind a large number of your population have chest infections, it is important to know where you're listening and what you're listening to. not been programmed that I should be teaching you how to listen to heart and lung sounds. So we're not planning to do that on this visit. But maybe in the future we can do that with you. And what we have here are showing the position of the lungs from the anterior aspect, from the front of the patient, and from the posterior aspect. So we've got three lobes on the right-hand side. Here is our upper lobe, middle, and lower. And on deep inspiration, they expand down as the diaphragm drops down. On the left-hand side, primarily at the front, you see the left upper lobe and a little bit of the lower lobe. Very important if you ever get to listen to a pair of lungs, that you know which lobe you're listening to as to where there's a problem. At the front then, primarily we're looking at the upper lobes, with a little bit of right middle and a tiny bit of lower lobes, but at the back of the patient, you'll see that it's primarily the lower lobes that are exposed with a little bit of upper. So when you're diagnosing or examining a patient and you can hear that they have a problem in one particular area, it's important to be able to say to the consultant, this is the area that I'm hearing a problem. I haven't been assessing patients for more than a couple of years. When I picked up a patient who had total absence of air sounds in the area midpoints on the right-hand side, and got an x-ray done. And because I was able to focus on the x-ray request that this patient had an absence of air sounds around the right middle lobe region, they focused in and they found this patient had an undiagnosed neoplasm. So she had cancer in the lungs, which obviously took priority over the other procedure they were coming in to have now. Laterally, so looking at the side of the person, we can see a different aspect of the lung tissue as well. So how does that actually fit together with the rest of the preoperative assessment? Well, history taking that we've had a quick look at, and before I really deep in the go, but we'll get that going this afternoon, was looking at recording your medical history. Once you have done that, you then need to start looking at your observations of the patient. And it's important when we're recording our observations that we're noting what they are, the accuracy of the readings. But we need to think through, if that oxygen level is quite low, how is that going to be affecting our patients? When we take our air in, going into the lungs, and we're having the oxygen exchange in the capillaries, so the carbon dioxide oxygen exchange. And that is then going, the oxygenated blood is then going down into the left atrium, through the left ventricles, and then up the aorta to be circulated. Prior to coming back up the inferior cava or down from the superior cava into the right atrium, into the right ventricle, and then starting going back through to the lungs and repeating that circuit. So important that you bear that in mind and you remember that, because when you assess a patient, you're looking at how successful is that anaesthetic going to be. You want them to get through the operation, you want them to succeed. you want the patient to be oxygenated so that not only they survive the operation, but actually that they are going to recover from their cuts, their incisions quickly. A patient who has aortic valve disease, how do you think that is going to affect their successful anaesthetic? What are the problems that you can think of with that limited information I've just given you? You don't need to know more. If that aortic valve is not functioning properly, what will happen? No thoughts? Yeah? No? Somebody over here.
I think oxygen saturation will be very low.
Yep. Okay, so oxygen saturation will be very low. If oxygen saturation is low, what else will be happening with this patient?
Because the oxygen saturation is very low, oxygen supply in the heart will be impaired. So the patient is likely to have myocardial infarction.
Right. So there can be myocardial infarction as a result of having low oxygenation. Yeah. Okay, so there can be some oxygenation deprivation resulting in the cells around the whole body. In severe cases, one might have some very issues. Okay, in extreme circumstances, the aortic valve failed completely, very quickly, the cardiac arrest. Okay. I think the main point that I really want you to grasp here is that the aortic valve is a very key valve. If it is functioning well, then we know that the blood will be able to get out from the heart and be pumped around to the body, provided of course that the heart tissue itself is functioning well. But so often we find that the aortic valve, when it starts to fail, it doesn't keep all the blood pumping around, and some blood pulls back down into the heart. So less oxygenation is taking place around the cells, and that's what you're all coming out with reports, which is great. It's exactly what I wanted you to think through. So the patients who have aortic disease will need to have extra special care in terms of oxygenation with their anaesthesia. Check their oxygen saturation levels. You can either use a finger probe. I'm sure you have probes on other your machinery. I haven't seen all of your machinery yet. If the patient has heart disease, generally, do you think it will affect any other systems of the body? Yeah? Okay. So what systems in particular are you thinking about? Yeah, their lungs. Sorry, their lungs. Crucially, that you mentioned that because of the direct link here. So if the patient has some cardiac issues, there's definitely going to be some respiratory fallout because the anatomy of the cardiac and respiratory systems are so close together. Yeah? We are later this week going to be looking at ECG interpretation. I need you to start thinking, and that's why I've put this very quick summary of the respiratory system in here. I need you to start thinking about your cardiac system. cardiac system, without the heart pumping, you don't live. Right? Is that vital? We're looking at hypertension, hypertensive disease. We're looking at poor oxygenation, so the other cells of the body are not functioning, renal disease and so on. Okay. We're now just going to spend the last couple of minutes just looking at the chest anatomy that you might well see in the wards. Top left-hand side is your normal, healthy adult. That's the shape of a normal, healthy adult. On the middle at the top is a patient who is what we call a gravel chest, a round chest. And he was washing the elephant. And the elephant accidentally stood back on him. And we had a great big elephant print on his chest. So all his ribs had been depressed in. And obviously it was exceedingly painful for him to breathe, so we put him on a ventilator. But he did very well. He survived, and we had operations to try and lift the ribs out. Although there was an indentation, you can always see the elephant print there. But what is the danger if a patient has a fracture that's causing pressure down onto the lungs? Fractured rib, what's the dangers?
To affect the ability of the chest to expand, to take in air, and then breathing out.
Lovely. So it will affect the patient's ability to expand their chest and to breathe in and out. Yeah, it's going to be very painful. Sorry, what am I about to say?
I also think that it can also cause pneumothorax and pneumothorax.
What a lot. So, a flare chest because of fractured rib can cause a hemothorax, that's blood going into the lungs, and a pneumothorax, air into the chest, which compresses the lungs and stops them from expanding. Both of those are very serious, and the patient needs emergency treatment. The reason I'm bringing that into this session is that we have emergency patients here at the military hospital coming through, so you get a lot of trauma. The bottom right-hand side has called a funnel chest. The technical term is a pectus excavatum. What's happening is the sternum, instead of being straight, the surface is actually dipping inwards, concave.
While we are in a reassessment unit trying to do that, then we try to make sure that they are coming from home but they are not infected. So then they inform the ward. Then the ward comes in, gets prepared for the patient.
Yes, there are so many papers, so you can be writing and putting them all over the place. Yeah. So just say patient A, self-medicated.
So does it draw an arrow indicate?
So whatever comes to your mind, there are so many processes. You can be writing them, and then you put them there, and then link them. Arrow to here, arrow to there, arrow to there. You see what I mean? You get in the like, yeah. It doesn't matter.
Then the arrow. You just right. Yeah, you read.
An ambulance service.
Yeah. So if yeah, surgical. Let's jotted down there.
comes and then completes. So the other goes to the polyclinic, or the patient is just coming straight away.
We are talking about
Coming straight away
from here and here, they will pass here, but another one will
theater.
between there
Then
and
from
there.
here, theater.
Oh, so what should I write?
But not everyone goes to theatre. Some don't go to theatre.
Some
They
theater.
write
Some home.
theatre up there, and some go home here.
My theater.
In my theater.
My theater. Then some also go home. Becca have
T-R-E, theater. You get theater, Baba.
Then some also go home.
But others too go home.
Okay. Then
So this one home.
And where are they clamped? Between the consulting room and the bed?
Yes.
the clapping comes before the hospital bed. So this is
Black. Okay.
So now we take the other color forward.
So the ones that go home we don't care about because we're peri-operative. So the ones that go to theatre,
yes.
What happens to them in theatre?
Then you will need assessment.
Let's face reality. Okay, so what is this here? Our local condition. That can be a referral point. Right? So you write the local malam. You take in one patient, right? Any condition. And then for the medical assistant. From the medical assistant, refer to the lab for investigations or what have you, because they are going to check the history. Right? So by the time they go to see the doctor, what is it called? The clinician, the lab results will be ready. Right? So the doctor look at it and say, okay, well, I think you need admission. Admission go to what? 25. The 25 is
We don't have that here. So what you have?
This one is ours. We have the day of discharge and the
So say, it will be discharged to review, then to communicate. That is.
So when we are explaining it, then we tell them that the discharge is not the final discharge, and at the same time, discharge for review.
Yeah, discharge for review.
Review, double.
Review stroke rehab.
Because not all our patients, yes.
Let's say I was.
What is
good? Admission.
Then we check you again. Yeah.
So unfit for surgery, unfit back to the community, reassessment.
But I shouldn't follow admission yet.
Shouldn't follow admission.
Shouldn't follow
Fit for.
I don't know. Okay, we don't fit. We start from here.
Once the patient goes to the ward, the prescription is on this folder. So the ward will collect all items with them and then send here. Look at it so that you can go in. The ward, discharge ward. So go home. The ward, no.
This means day surgery.
We are going for
it hasn't been pre-booked. The patient walks in.
We are not going to do the patient.
Right. That's the same. The patient is not. Do you all work in the same place?
Yeah.
The same place. Okay. So then, the patient comes in first. See the doctor. Right? It is pre-agreed, so they know everything about the patient. Okay. Go home and come on this date.
Yes, that's how.
No. Then when does the patient go to the ward?
No, there are some.
Some of the patients, I made them at the ward before. See, that's what we've done. But some of them.
What it's doing is
financial control. Yes, and for review, we need car. Okay. Oh, it's time up.
Let's come and see what we've done. Welcome. Now, good. Would you like to take us through from start to finish?
Yeah.
Let me find you a mic. There you go.
This is what we have. Our clients come in. Some are referred from the community, that is the CHIP zone, to their OPD. Others come straight to the OPD. From the OPD, they move to the consulting room. From the consulting room to the anesthetic assessment, for anesthetic assessment. Then, those who are fit go for admission dates. Those unfit go for treatment and follow-up. Fit patients are given a date, then they are admitted a day before surgery. Surgery is done. Because there's no recovery ward, they are sent straight to the ward. They are discharged and they come back for review. But there are some constraints. At the OPD, there's long waiting time over there. At the anesthetic assessment, there's lack of privacy. So they are not assessed well. Then on the day of admission, some of the clients don't honor their appointments. They don't come on the day they are expected to come. Sometimes they wait when they are satisfied, they turn up. Then surgery. Sometimes surgery is delayed because there's inadequate logistics or technical fault. In our area, we have a power fluctuation. So sometimes it can affect surgery. Sometimes you have an elective case, then an emergency is brought in, so there's lack of space. You have to bring the elective out and take in the emergency. That's another constraint.
Before you go on that one, could you perhaps write lack of dedicated elective lists or lack of dedicated emergency list? Yeah?
Okay.
Yeah? Excellent.
Then, and on the ward,
sorry, that problem comes because the theater perhaps has only one table.
And there's an emergency. So the plan has to be suspended and the emergency taken out.
So the problem is because of lack of the medical team, not the patients. Okay. Yeah.
Then on the ward, because there's no recovery ward and the patients are sent straight to the ward, the patients are at risk of being monitored well. It also puts pressure on the staff on the ward. Because if these patients were to be at the recovery ward, at least they will be monitored for the first 24 hours before they are sent to the ward. But from surgery straight to ward. And at the ward, there are no gadgets for them to monitor. Then review, there's another constraint. Sometimes because of lack of finances, the clients don't turn up for the review. And even if they come too late, they turn up at the right time. Thank you.
That sounds wonderful.
Sorry, we have some silence again, folks. That was excellent. And I'm looking forward to seeing what the rest of you have put together. Okay? Each hospital may well find that the pathway is slightly different. That's fine, that's good. And it's because the pathway has evolved to suit the needs of your patients, your clients. What you're doing right now is thinking laterally. You're thinking outside of the historic box. Yeah? So I'm very proud that you've done that, very proud of you all for doing that. That's a wonderful achievement for today. So congratulations to every single one of you from me and Now I'm the one, yeah, with something colour-coded in it. So one of them will be coded a red or an apricot colour. What colour do you say that is? Apricot? Red?
Red.
Red. So those of you that have got red on your identification badges, yeah? I can tell you who that will be. Would you like to? Yeah? Yeah? Oh, I can't let this red go, but you've got red on there, yeah? Is that red or is that no? That's purple. While you think of any questions. So, primarily I think we're going to put a Paul actually. So, Paul, would you like to come and join us up at the front? And actually all of the MotecLife team, would you like to just come and join us at the front? And have a sit down on these chairs. What we're able to do is look through, very briefly, the strategic plan for Ghana. We have then looked at history taking, followed up by a little bit of anatomy and physiology of the respiratory system and how it interlinks with the cardiac system. We then followed that through by looking at the DVD about history taking, because when you did the group work, you found it quite challenging trying to take a history without a guide, without a pro forma, without a page telling you next question. And what we realised was actually if you have documentation to guide you through step by step of the process, it makes life easier. One of the important words that I stressed throughout the day was need for accuracy, identifying patients' health concerns, signing, dating, and timing everything that you write, and printing when it can be misinterpreted. I think I made reference to Paul's handwriting. Oops. So you might hang your head in shame. So, we covered all of that. And then this afternoon, you have produced some magnificent work, which Paul, you're going to have a look at. It's about process mapping the surgical patient's pathway. And they've looked at this by putting into groups, some from the same region, some from the same hospitals, although one of our delegates here is the only person from her hospital, so she's joined another. So it's been some magnificent work. We've had one of those presented back. The rest we're going to do tomorrow morning. Alright, so they're not going to go under the carpet and be ignored. We're going to look at that in more detail tomorrow, and you'll hear what else you can do with process mapping. Okay, the final bit then is now down to you. I asked the question from you earlier, how am I pitching this? Is it too high, too low, or in the middle? Yeah? Everybody happy it's in the middle? Yes. Brilliant, well done. And do we have an agreement that if I'm saying something that's not quite right, you're going to come back and tell me? Yeah? You happy with that? Yes. Yeah? Brilliant. Because what I don't want to do is keep spouting on and I've lost you half an hour ago. Alright? So maintain that for the rest of the week, that's wonderful. Okay, so the groupings are on the board, which you're going to be able to see on your way out. If our colleagues can come and have a sit down. So Felicia, Leslie, come and have a sit down. Dave, by all means, join in if you want to. It's over to you now. What questions have you for Motec, for me? And we're going to try and answer as best we can. I can already see our hands going up over here. So
we've learned a lot about planned surgery and all the steps and processes that are involved. And I know when it comes to emergency, it is a different story. So I don't know whether we are yet to learn more about it or we're going to leave it for some other time.
Much more rapid. However, the principles remain identical. Patient identification, confirm any past medical history that you have, any anaesthetic problems, observations are going to be there, the patient safety aspects are going to be there. So these principles apply, but you're quite right, for the emergency patients, when do these apply is different. And that's why I wanted you to do the process mapping. Because what we will look at tomorrow is your process mappings, which you're all going to feed back. And then I'm going to say to you, right, what would be different if this was an emergency patient? Okay? And then we'll look at that separately. So yes, thank you for that. Preempting tomorrow, but that's no problem. Anything else?
Mine, I don't know whether it's a suggestion. I've seen that anytime we come for workshops, there are some slight differences in the practice done in your country and ours. Is there any plans to collaborate with the school so that some of these will be inculcated in our curriculum before we come out?
Yep.
I think it's a question we have asked ourselves. But we have a way of looking at it. We're going to deal with the institutions, we're going to deal with the working staff, and also the authorities. And if we can get all the three together, then we can formulate some policies which could then go to the national level. And I think that the only way these things can work is to have kind of pilot studies that the school, the hospital, and the authorities agree. So you can start the process, whatever you think is right, you discuss with your management, and the management can decide whether it's a policy or not. It's happening in some hospitals that we worked in the Western region, where individuals, after lectures, have sat down with their authorities, even to draw protocols. As a matter of fact, we are not actually here to tell you what to do. We tell you what we do there, and we pick the best according to your circumstances. But the circumstances, we need to look at it carefully because we don't want to stay where we are forever. So that's how it's supposed to be. Some of the things we hear from you, we pass it on to even the health minister, Ministry of Health. So the regional ministers of health, they are aware. So it's a very good question. We think about it, and hopefully we'll be able to address it better.
Thank you very much, Paul. Thank you. Any other queries? Yes.
Abbreviation MotecLife was explained earlier, but I didn't get it also if you could be taking any.
MotecLife comes with a story in which individuals, in which the family identifies a problem in a particular hospital, and a discussion as to how to address the problem in that hospital. And the family thought of moving people. This hospital we're talking about is an orthopedic hospital, which is for Peri-Operative, which is the first hospital we started working in. So we thought of moving orthopedic people with trauma experience and to educate. And we're going to count on our capabilities, which is C. So that is MotecLife. Movement, orthopedic trauma, education. T for transfer of skills and counseling. So essentially, that's how it was formed. But we realized that that is not enough to help everybody. If you went to a hospital, and you decide to help one particular group, and you leave the others out, you cannot grow. This will grow, and the others will pull you down. If you operate on the patient goes to the wall staff manage the patient if they are not being part of the chain. So effectively, it involves life. So we think that, or we thought at the time, that MotecLife should be dealing with life. And that is how MotecLife came about. And the life doesn't just mean life, but L stands for leadership, learning, I, industry. We have to be industrials. And we've got to be faithful to ourselves and also economical. That's what it is.
Thank you very much. Anybody else with any queries, comments? Have you all enjoyed the day? Yes. Excellent. You're going to come again tomorrow? Fantastic. That's all with one question. Hold on. Hello.
Thank you. Training of theatre nurses in hospitals, maybe outside, and especially with the trauma and orthopedics. How does one get the opportunity to be trained in that? Because I think it's very good. In Ghana now, where we have a lot of RTAs, if most of the peri-operative nurses who are not gotten that specialty area are taking through it. It will go a long way to help our patients.
What MotecLife does is that MotecLife tries to see the need for the training. Because if we decide just to train people, they might go back to an environment that wouldn't work. And we have noticed we've had one experience that somebody trained in India went back to the hospital and was not allowed to merge the ideas from both sides. So when we see a pattern, that seems to suggest that the hospital needs that kind of service. And the individual is also interested in coming back to share the ideas with the colleagues. Then we act. Thank you.
Variant CJD. Those of you that didn't hear the question, during one of my presentations I may mention an infection that is bloodborne, we think. And that infection is called variant CJD. I'm going to need to write it up on here for you because it's a variant Creutzfeldt-Jakob disease. That is spelt, as in a variant, CREUTZ VELDT, Creutzfeldt. Second word is Jacob, J-A-C-O-B, and then disease. I will write it on the board here for you. Any other queries? On my behalf, please. If tomorrow morning I think I just can't face coffee on and shift dress, would you mind if I came in my shorts and my t-shirt? No problem. Thanks. I've been dancing all day. Okay. Well, time I think for us to say, thank you very, very much for taking the time to down here. You've done a fantastic job.
We'll be happy.
And thank you for coming.
Hello. We started with a prayer, and I'm sure somebody is going to end with a prayer. Joel is not here, is he? I don't know what is any announcements to make, but who is going to pray for us? You. Announcement, okay.
Hello. Yes. We are glad you are all here. And we will be glad you are all here tomorrow. And on time. Today, the supper would be in at 5 because we thought we would close at 4:30. And then by 5 o'clock we'll start having our supper. So it means you would have to wait an hour because it will be brought here. So we'll wait for our supper. That is the announcement for today. Thank you.
On that side, if those of you want to finish your process mapping, you can, it's up to you, but otherwise it'll be tomorrow.
So if you want to continue with the process mapping, if you think...
Father, we thank you for this wonderful day. We thank you for the grace you have shown upon us, for making this conference a success. We commit ourselves into your hands, even as we leave for our various homes. We pray for your presence and your guidance, your traveling mercy, those of us who will board vehicles back. We pray that your grace will be abundant upon us. Keep us even as we go today, so that when we see the sunrise tomorrow, we give you grace, adoration, and exaltation. We thank you in Jesus' name.
Amen.
Beni, Oto Kemi.